我代
On,
表
on,
我
on
们第一
behalf
小
Group
组，我
1, I
来
will
给大家介
present
绍一下我
our
们讨论的
discussion
结果。
here, and the
我们的研
study
究
title will be
题
Phase 1
目
Dose
是
Escalation Study of Trametinib
Trametinib 和
and
Cisplatin
Cisplatin in patient
有这
with
种
advanced solid
晚期的
tumors. And in this study, because based on the preliminary a number of study on Trametinib and other chemotherapy, other cytotoxic agent, and we have select Cisplatin as a combination. And here we designed this phase 1 study as a single center, maybe because we actually did not discuss this design in detail, but I think it should be a single center and open label study here. And to evaluate the safety, pharmacokinetic and pharmacodynamic of escalating oral Trametinib and intravenous Cisplatin in subjects with advanced solid tumors, which there is no accepted standard therapy. And the objective of this study, the primary objective will be evaluate the combination safety, tolerability, and dose-limited toxicity for RPTD. And the secondary objective is the Trametinib, the PK of Trametinib, and the preliminary efficacy. And if possible, we will evaluate if there's any screening any biomarkers for further study. The inclusion and criteria, the selected would be the patient with solid tumor with measurable or evaluable lesions based on RECIST criteria. And the patient should have no standard treatment. And with informed consent, the patient must be understand what we're talking about to the patient, tell the patient. He may not that the patient should be in the age 18 to 70 years old, because some of our members suggest that maybe if the patient is too old, maybe he cannot receive the dose of Cisplatin. And the performance status should be just ECOG peak as 0 to 1. And the patient have a normal liver and renal function, adequate bone marrow and cardiac function, because the preliminary studies show that this drug Trametinib could have cardiac function, affect the cardiac function. The exclusion criteria include the following items: previous treatment of platinum, any platinum, within 6 months of the study entry, and the patient have received systematic anti-neoplastic therapy, chemotherapy, or any biologic or radiotherapy within 28 days preceding the initial of the study agent. And the patient have significant visual order in previous medical history, because the Trametinib may affect the patient's visual venous, and the patient has NYHA classification, high value classification grade 3 or 4, and because this drug Trametinib is oral agent, so he have to the patient must be can swallow the pills to allow include in this trial, and maybe the patient have no current diagnosis of brain metastasis. And this has not been further discussed in the discussion, but one of the members has recommended that this include in the exclusion criteria. And this is the dose escalation schedule. The design here, then we split into 4 dose level. The first dose level include cisplatin 75 milligram per square meter in day 1 and Trametinib in 1.25 milligram per day. And the treatment will be start every cycle every 21 days for 1 cycle. And we in the discussion, and so some of the members suggest that the cisplatin dose starting from 60 milligrams, but Dr. Xu and some of other the members think that maybe this is too low for the dosage. So at last, we just use a standard dosage of cisplatin. And the Trametinib, though in other study they have reached 2 milligram per day, but we think that for safety, because in a combination, just study from at the beginning we suggest from 1 milligram per day, but after that we have get agreement that we study from the 1.25, because there's it's in other studies relatively safe in this dose level. And the second level, we escalate the dose every 0.25 milligrams per day. So in the second dose, it's 1.5, and third dose 1.75, and the fourth dose increased to escalate to 2 milligrams. And it designed 3 past 3. That if there's the first dose, 3 patients, if there's one dose limited toxicity, will withdraw this dose, and if there's one dose limited toxicity, we will have to further more 3 cases include in the trial. In this dose level, if there's find one DLT, then we will go for we'll stop this dose level. Or if all the patient have no dose limited toxicity, we'll go to the second dose level. And the definition of dose limited toxicity here is we discussed these four kind of dose limited toxicity. The first is grade 4 hematological adverse event, including grade 4 neutropenia over 7 days, and febrile neutropenia, grade 4 thrombocytopenia. And there's, according to the previous study, and here we define as the grade 3 non-hematological excluding inadequate treat, nausea, vomiting, alopecia, because of some of this toxicity is about not adequately treatment by the toxicity of cisplatin. And we defined as grade 2 retinal venous occlusion as dose limited toxicity. But this is, though there's no record that the grade 2 retinal venous occlusion will be prevent patient continually receive the treatment. But during the discussion, we are not very sure that the retinal venous discoloration, the CR is how much it affected patients. So we defined it as grade 2, and another is grade 3 cardiac grade 3 or over, or grade 3 or 4 cardiac toxicity. And the PK, we will test the PK for all the patients. And time point is day 1 will be the 0 and half hour, and 1 to 4, 8 to 10, and 24 and to 48. We have discussed, at first we have suggestion that 12 hour, but Dr. Xu think that because of the time will be very late, that will be affect the patient's sleeping or take a rest. So the only study 12, 4, and 48. And the trout levels is on cycle 1, day A, 15, and cycle 2, day 1. And the parameters, the PK test including half time and AUC and peak time, Cmax and Tmax. And according to the biomarkers, and we have suggested that if possible, we will prefer to taking tissues from or safe tissues for further molecular study, just blood samples before treatment and biopsy before treatment, and after progression if possible. But because this is a phase 1 study, so this maybe is too difficult to get that much samples or tissues from the patients, and maybe not necessary too. But this is discussed on our workshop, and if possible, could this biopsy or blood samples could facilitate further molecular study, including EGFR mutation, KRAS, RAF per PERK study, and could be find molecular for further screening. Okay, thank you. This our report.
Thank you, Dr. Yang. That was a very good summary of the discussion. Do we want to take are there any questions? We decided not to molecularly select into this phase 1 trial. There was some discussion whether we should have selected, but because there is cisplatin, we discussed that perhaps it's not so easy to limit it, and we might see activity even if we do not molecularly select. I think the other thing is we were struggling that we don't have any preclinical data to combine with cisplatin, but we can't create preclinical data on the spot. So we thought this was a broad, good drug that we could use in combination. But ideally, I think to go forward for a phase 1b study like this, there should be some compelling preclinical data to show that. Professor Mark?
Tony, please. This is a very meticulous design, phase 1, a very classical within 1.5 hour, I have to say. But I want to bring this up to the floor, especially with a phase 1 expert of the world, is that about the concept of combination of chemotherapy and a molecular targeted drug. I mean, we have seen so much failure that some promising of improvement, either synergism or some additional effect in the phase 1, 2, but when it comes to phase 3, it turned out to be all failure. To me, I mean, in a sense, is that targeted drug, meaning hitting the target. Once you have the chemotherapy and combine with targeted drug, I cannot see a strong rationale anymore in a way of move forward. So I just wonder, I may have missed the first part of your discussion, but I just wonder whether this is the direction we should avoid, or we should still go on with chemo plus a targeted drug.
I think it's difficult to make a sweeping conclusion that from now on we should not combine chemotherapy with targeted drugs. Certainly there are cancers we know that combining chemotherapy with targeted drugs is beneficial with a survival benefit. So I think in this situation, because there's so many potential preclinical combinations you can do with the drugs we have in development, targeted and chemotherapy, I think the focus really is a lot of what Patrick has shown this morning about the preclinical assessment, or even after a clinical study, learn from the experiments that you can do in the lab before you take it in the clinic is crucial. Because I think it's easier to do it in cell lines and good cell lines and mice than to do it in patients' resources, which are so precious. So I think there are a lot better models now than we did, 20 years ago, that we can actually understand a lot more to allow us to move forward. If we had known Patrick's data, I would have recommended the MET and MET combination in our group for sure. That would be a lot more compelling, and then quote your data to justify our trial. But given the lack of it, that's how we decided to come up with a chemotherapy that was common.
Okay. I have some statistical question to ask you.
Ask him.
I understand that you only have a very limited time. And also, since I need to be rotating among different groups, so I cannot stay there, in the later part of the discussion.
To give them fair, they wanted to use the CRM, but
okay.
We said you're not there, so
That's
let's
right.
do this 3+3.
Okay, so in terms of 3+3 design, I know that this is a very commonly used, simple, easy to implement design. But have you thought about after you reach the MTD, okay, then what's next? Typically people use the expansion cohort, and try to learn a little bit more, both the toxicity and efficacy. And since you also try to plan to collect tissues and maybe do some molecular profiling. So have you thought about, suppose you reach to the MTD, okay, then what's next?
MTD, I think we have to, because based on the pharmacokinetics, I think we will, after that we will define that we'll define the optimal doses for the phase 2 trial. I think that we can go for a phase 2 trial. If there's I think we'll go for phase 2 trial.
Yeah, do you consider before launching a phase 2 kind of expand the cohort at the MTD and maybe in a certain kind of setting, if you see some efficacy or you like to use your molecular profile to inform you that what to do next? I think that for the phase 1 study, you need to look beyond the phase 1 study, and you need to think about how you can get the information, what kind of information you need to help you to plan for phase 2. I think that's
because at first this is the try to evaluate the safety and the tolerability of this combination. Because we use Cisplatin, which is this combination. At first, I have to confirm that this combination and the best dosage. And actually, I have no very extensive knowledge of this, how to scheme the dose level. And because after we have the MTD, we go back to maybe those level and think as the best tolerable dose level, and then I will find that if possible, we can have this. We can learn. We can find out how many of the patients will be effective, because we have measurable or evaluable lesions. If possible, maybe we can find 1 or 2. If we have 2 patients is effective, then I think that and if we luckily have these patients' blood sample or tissue sample, and these samples could be can be tested for any kind of this molecular profiles, and further if we can luckily find any connection, and then maybe
I think he wants to expand based on what he learns from the dose escalation, which is not unfair. I think to commit to an expansion without knowing what you see is difficult.
That's right.
I think in light of time, we should move forward. Thank you, Dr. Yang.
Okay. We move to next